Thank you, everyone, for being here this morning for our first workshop in our ACES and Trauma Working Towards Resiliency series. This series is organized by members of our Strafford County Addiction Task Force. My name is Ashley Wright. I'm the Continuum of Care Manager for the Strafford County Public Health Network at Greater Seacoast Community Health. Part of my work is to facilitate our Addiction Task Force, which works across the community to strengthen the continuum of care in Strafford County and bring together those working across the community to collaborate in efforts to prevent substance misuse and to support those seeking treatment and recovery from substance use and mental health disorders. Our Addiction Task Force meets the third Tuesday of each month, and we welcome anyone to join us. Some of those members are on this workshop, and I would like to recognize Vicki Harris from the Dover Coalition for Youth, Nicole Rodler, from the Rochester Police Department, Cora Long with the Public Health Network, and Mark Lefebvre with the Pine Tree Institute, who's also a facilitator today, for your help in making this workshop and this series possible. Feel free to reach out to Vicki, Nicole, Cora, or I during the session if you need any assistance with your Zoom or have any sort of technical questions. Today's workshop, Understanding ACES, Building Self-Healing Communities, is being presented by 3 of our partners in the community who have become master trainers with the ACE Interface Project in partnership with the Pine Tree Institute. Jody Langelotti is an OCD and anxiety advocate and educator and serves as president of OCD New Hampshire, the state-level affiliate of the International OCD Foundation. Steve Papajohn, Youth Services Coordinator for the Dover Police Department. In addition to all his committee and work group involvement, his 2 main responsibilities for the police department are Director of the Dover Teen Center and Coordinator of the Dover PD's Juvenile Court Diversion Program. Our third presenter, Mark Lefebvre, is the Community Engagement Director at the Pine Tree Institute. He's also a member of the Governor's Prevention and Recovery Task Forces and co-founder of Safe Harbor Recovery Center. So we hope that this workshop will provide you with a strong understanding of the science behind adverse childhood experiences, the implication that ACEs has on long-term and mental and physical health, and will allow you to begin thinking about how you can build resiliency in the individuals and communities that you serve. So we invite you to visit, I invite you to visit the events page on our website, scphn.org, to find more information about the next workshops in this series that will hopefully build upon the knowledge and skills that you learned today. I will enter my email into the chat if you have any questions about upcoming workshops, or if you would like to become part of our Addiction Task Force, please feel free to send me an email. Thank you all again for being here the time. I know everyone is very busy on Zoom, jumping from meeting to meeting, and that there's a lot going on today. So we appreciate your time. Thank you for being here, and I'll hand it over to our presenters.
Thanks, Ashley. If we can go ahead and get the slides up, please. We'll jump right in. Thank you, everybody, for joining us today. We're going to kick it off with Steve Papajohn.
All right, while that slide's loading, everybody give a little stretch, a little something. We're going to dive right into this stuff, have some fun together. Thanks for joining us. We're excited that you're here, and we're gonna share some stuff with you and hopefully leave you with a place to take it further. So we can go to that. Just real quick, some housekeeping stuff I think that Ashley put up for us. Read through those real quick.
And just so you know, I did put a fillable PDF into the chat for the executive skills questionnaire. You will be using that during Steve's part of the presentation. If we have a lot of communication happening in the chat, when we get to that point, I'll go ahead and upload it again for everybody.
Awesome. All right, I think we can take that next slide up now. All right, cool. So the part that I'm going to lead everyone through has to do with a lot of brain function, neuroscience, epigenetics, ACEs, and resilience. This is kind of like the track that we're going to follow today. So I'm going to kick us off with a little bit of the neuroscience background, just so everybody gets a foundation of this brain development stuff that will kind of give us that first step. Next slide, please. Awesome. So we're going to take a look at this really huge public health discovery that we've stumbled upon and brought us to today. We're going to share some findings from the Adverse Childhood Experience Study. We're going to refer to it throughout the presentation as the ACE study. Basically, what we have is this study that through that was looked at with adversity through life experiences that increase physical and mental and behavioral problems later in life. The ACE study was the largest of its kind. You can see over about 17,000 participants. It was developed and co-sponsored by a managed care consortium, Kaiser Permanente, along with the Centers for Disease Control in the early 90s. Doctors Rob Anda and Vincent Folletti were the two principal investigators of the ACE study. And much of what we're going to cover today comes from their study, and we're going to take a deeper dive into that. Next slide, please. So real simply put, neuroscience helps us understand why ACEs are so powerful. So before we dive into the findings from the study, we're going to take a look at some brain development info. We kind of have a basic, from our high school biology days, we know that this nervous system orchestrates our internal body functions, as well as the perceptions of the world around us, how things affect us, those kind of things. Cells throughout our nervous system are called neurons. They're in constant action, processing and transmitting information from those external experiences. And neurobiologists really get into this, and there's continued research on brain development and how trauma can lead to these ACEs. Next slide, please. So we're going to dive into something that we call synaptic density. On the far left, you can see brain cells or neurons, as we mentioned, how they might look like at the time of birth. There aren't many connections between these cells because babies are born with only the connections and brain functions that they need at that point in life. So most of our wiring really occurs as the result of life experiences from the senses we experience. So by age 6, you can see some brain cells have a bunch of connections. The wiring of our brain is very experience dependent. What gets experienced tends to lead to more connections between the nerve cells from our networks. So if you picture kind of a tree growing and branches kind of expanding out, we call this process arborization. The last section gives this representation of this age 14, kind of about the time of puberty. And you can see that there are now some fewer connections between the brain cells than there were around age 6. The reason behind this is that the least experienced connections tend to fade away about the time of puberty. So what we kind of call this, again, with that tree kind of picture, is pruning. And this kind of helps to explain why neglect or not getting the experiences that we need have such a negative impact on our health and social functioning. Next slide, please. So to look at this, we're going to kind of look at two paths. We're all very unique. Each one of us have had different experiences, and basically we're going to look at these two paths. The top one, if you will, kind of is this mean and dangerous world. And the second one is kind and generous. So traumatic experience during that development, like abuse, neglect, maybe chaotic relationships, can form these predictable patterns of that brain architecture that leads to these behaviors and traits. So if you think about it, as humans, we're kind of really built to endure stress at maybe like a 20-minute max, which is long enough for each one of us to decide that kind of fight, flight, or freeze response. So experiences kind of maybe like childhood abuse or neglect that cause stress chemicals to be produced have that huge impact on our brain development. Under these circumstances, we tend to prepare for a life along that top path, that mean and dangerous world. So let's dive into that top spot, that top line. Stress hormones influence our cells and the chemicals in our brain wiring. They basically sculpt brains that end up wired for certain characteristics, like being edgy or hot-tempered or impulsive or being withdrawn or numb. For example, those folks that have had traumatic stress from birth through the toddler years might have that higher baseline of stress hormones, for example, cortisol inside our bodies. Common outcomes, if you think about it, from this example might be having a shorter fuse or anger issues, being kind of having self-focused behavior, or even exhibiting a difficult time shifting gears from emotion to problem solving. There's sometimes that block. What we do know is that when stress hormones like cortisol, like I mentioned earlier, hang around for a long time, they're super toxic to our brain cells. And this toxicity makes it difficult for the brain cells to develop those healthy networks that we need to happen, that arborization. So in some cases, we even see brain cells fade and die. And this is why we often call that continuous stress, that trauma, that unpredictable, like episodic stress, toxic stress. So knowing that, let's shift to the bottom line. Because this world is typically kind, generous, little less stress-free, we typically experience that as kind of like an easygoing and helpful and free of that traumatic stress. So people that grow up through this path are a little more likely to develop a brain for being focused, being a little more flexible, and being relationship oriented. It comes to them a little bit easier. Next slide, please. So you think about it, what kind of situations might be a good match for a person who tends to be edgy, hypervigilant, emotionally attached, or quick to act. How might these kind of things and these adaptations be useful in our environment? I think when we break it down, one of the things we believe is that people whose experience take them along that top path, that dangerous world, are kind of maladaptive. They're people that, and that the people on the bottom path are a little more adaptive. They're easier to get along, to get through things. It's kind of a myth. It's really not true, because both pathways really are adaptive, because both brains are taking the time to take in the experiences around them and then create a response. And that's good for us, because we need people of all kind of response levels. The people whose brains adapt to that dangerous and stressful world are probably a little more weathered and likely to survive when life gets tough. And the people whose brains have adapted to that safe world are a little more likely to be prepared to meet expectations in calmer times. The long and short of it is that our experiences get hardwired into our brain and our biology and create who we are. Next slide, please. So when biology collides with social expectations, we tend to run into trouble. So what does that mean? If you take a person from that kind and generous world, that lower path, and put them into a chaotic or turbulent environment, maybe say like controlling a riot control type situation, that person's going to struggle unless they've learned some of those very specific skills. And on the flip side, a child that maybe adapted to that dangerous or stressful world, that top line, may not exhibit a good use of patience. They may be quick to react, not think things through. And they may not be able to cooperate or effectively communicate and use words as their first choice. So in the end, when you think about it, biology wins. Whatever we get hardwired with, we have to develop responses to. And problems kind of arise out of those, societal expectations that don't match our own hardwired responses to stress. But the good news, like in most cases, because as people know me, I'm the eternal optimist, so I believe in this always, is that we can teach skills. We can kind of get to a place where even when we face situations that don't match our childhood experience, we can adapt and overcome and find a way to make things through. Next slide. So if we take a look if we take another dive deeper into one of the factors that determines that brain development when trauma is present, you have to ask that question of why would the age of a person at the time of trauma have that powerful effect? Simply said, our brain develops in a sequence from most simple to most advanced. So if you think about it, if you start with a baby doesn't need to be able to submit a report, send emails, pass a math test, things like that. But the baby needs to breathe, eat, sleep, and connect with someone who is their nurturer, their primary kind of caregiver. So parts of the brain that control that internal body functioning and ability to connect to that primary caregiver develop at that earliest stage. As the brain develops, we see this really awesome kind of phenomenon that involves experience and adaptation, generating those age-appropriate retentions for like feeling, thinking, and responding to the world around us. Next slide, please. So as a baseline, we kind of obviously understand that toxic stress in early childhood has these profound effects on brain structures and functions that tend to develop later in childhood. These functions include things like thought process of like emotional responses, social interaction, abstract thinking, things of that nature. And that's why our early childhood development is so important. But it's not really the only sensitive developmental period, according to some of the research that we've been taking in. So, for example, if you think of that 7 to 13 age range, emotional and verbal abuses can affect the centers in our brain for processing sound, like if we shut down or if we listen, developing verbal language, if we respond verbally or if we tend to freeze up, and understanding, those social cues, like being able to pick up on a vibe from another person. So by the time we hit our late teens and then on through our late 20s, our central nervous system with the brain at that top command center spot really orchestrates everything from our automatic body functions like breathing, heartbeat, temperature, to even to the most complex goal-oriented behavior and our ability to have that abstract analytical thought process. Something to keep in mind really is that people that have experienced that toxic stress during development it can feel really small to one person, but it can feel very overwhelming to another. Next slide, please. So at this point, what we want to do is give you a chance to talk about executive skills. These develop early in our life. Working memory and flexible thinking are used in our day-to-day interactions from dating back to our preschool years for things, if you think about it in that time period, games that require series of steps, learning to take turns, and group activities that include responding to cues, like when you're called upon or taking those steps. we continue to develop these executive skills listed throughout our lives. And it's a good thing because we need them to set and achieve goals, to participate and complete complex tasks, and they're obviously help us get from point A to point B. Something to consider is that we all have strengths and weaknesses in these executive skills. It's also really normal to experience maybe like a dysfunction with these skills during high stress times. Think about it. If we're overwhelmed or feeling this way, we may not be able to retain information in our working memory. We may be kind of sitting in quicksand and not being able to initiate a new solution. We may not be able to think clearly that way, and we may lose track of time with things. We may become a little more challenged with our time management. And if you think about those things that might come up, it's probably a great time to be working as part of a team. So if you're facing some stress and your working memory is kind of being challenged, you might want to explain to others that, being able to take detailed notes is easier for you instead of just letting things pass first. That might be easier for someone else. So if you look at the list, these are kind of our two columns: response inhibition, which includes working memory, emotional control, flexible thinking, sustained attention, task initiation. And then under planning and prioritizing, organization, time management, goal-directed persistence, and metacognition. So what we're going to do is actually ask all of you to take the executive skills questionnaire. I believe it's in the chat, and you also got it sent to you, I think, in an email. So we're going to put kind of an 8 to 10 minute clock on and let you all take a moment to fill that out. And then from there, we're going to send you into a breakout group where you can just kind of discuss for about 5 minutes your findings, things that surprised you. And when we bring you back, we'll welcome you and take our next steps. So for those of you that didn't have a chance to walk through the questionnaire, it's a pretty quick thing. So basically what you're looking to do is to give each one of those lines in each alphabet group, A, B, C, D, and so on, a number, whether you strongly agree or you strongly disagree. And you add up that number for each group, and then you kind of delineate your top 3 or 4, paths. And you kind of get to see what your high numbers are, your strengths, your low numbers are your weaknesses, and just gives you a chance to open up your eyes. If you haven't done this kind of measuring of these kind of the quotients that make out those executive skills that are listed on the second page, A through K, gives you an idea of where you stand. Some people, I think, find it eye-opening. Some people are like, oh, yep, you know what, knew that. And you kind of can take what you want from it. So for those of you that had a chance to talk about that in your breakout groups, what we were encouraging you to do is head over to the chat and maybe just throw a few words from your experience, sharing and finding out a little bit about your executive skills. We'll just give people like a minute to throw some stuff in the chat, and we can all kind of watch some of the comments come up, and then we'll move on to our next section.
And Steve, it's the lowest scores are actually your strengths? And
oh, sorry, yeah, you're right.
Are your weaknesses.
I'm sorry, yes.
So it's just all in the way that the questions are worded.
Right. Just to wrap up our executive skills section, we found that, when we share this with folks in training, especially since we're talking to mostly colleagues and folks that are doing a lot of the work around this and have some sort of cause and effect with ACEs and building resiliency and working with populations in that way, it's just a nice reminder to see where you really fall and how you can challenge yourself in certain ways. I think we're all trying to do the best we can. And sometimes a quick little analytical survey can point you in a direction, open your mind, make you think of something. And hopefully that's what it did for you today. All right, I think we're going to move on to the next slide. All right. So over this first portion of the day with me, we looked at how toxic stress can affect brain and human development. We know that during those childhood years, there are all these windows of opportunity to build resiliency. By protecting kids, providing challenges and supports that might repair those early periods of toxic stress. But as the slide suggests, we have a collective choice. We can continue to actively develop skills, make accommodations that enable everyone to contribute to, starting as small as a family, to a community, to a neighborhood, to our entire population. Or, we can continue to put a blind eye and follow this crazy societal pattern of rejecting people when they have these normal adaptive responses to childhood adversity. If anything, the key takeaway from all of this is that this toxic stress is hardwired into our biology. It finds its way in there. It translates into how we react to things. And before we assume that, a person's behavior is this rebellious choice or something against the grain, we need to consider the possibility that adversity may be at the heart of the challenges or behaviors that we see. Next slide, please. So now that we have an understanding of how this toxic stress can affect us person to person, individually, we're going to switch gears and see how it affects kind of our population, like the greater masses. When we think about that kind of study, we call it epidemiology. You've probably heard that term before. Epidemiologists are scientists who study origins of disease, disability, productivity, and general health in a larger population. They help us as a body to focus the collective efforts of all on issues and processes that will make the most difference for the well-being of everyone. And I think Jody is going to take us through that next section.
Thank you, Steve. Next slide. So the ACE study hypothesis is that ACEs disrupt neurodevelopment, which leads to adaptations. Steve talked about that, right? It's not maladaptive, they're just adaptations, but it's either on that leads us in a positive direction or leads us in not a great direction. And this leads to increased risk factors. And this breakthrough in research in epigenetics and neuroscience shows us that the hypothesis of the ACE study is sound. And so when we start to go out and talk to people about this, and I'm going to talk more about this a little bit later, the science behind this is sound. And it allows us to talk confidently about what we're going to share with you and what we've been sharing with you already. So in taking a look at this pyramid here, imagine that someone's living their life kind of up from the base, up through the center of the pyramid. And it really can represent the journey that we take. And I apologize for any background noise that's going on. All of the animals in my house have decided at this one moment to start having issues. So at the base of the pyramid, we're starting preconception. This is our grandparents, our parents, and their historical trauma and the intergenerational adversity that they've struggled with, which then leads to our own adverse childhood experiences. And we know that that creates neurodevelopment changes, and we have epigenetic influences. And as we go up the pyramid to that next level, that pink level, that leads to that social, emotional, and cognitive functioning and adaptive behaviors, which then bring us to the health risk and behaviors where we're struggling. And now typically when we think about prevention and we think about addressing some health and social problems, we typically focus on the top 3 layers of this pyramid, because the health risk and behaviors then lead to disease, disability, and social problems, which then can lead to early death. But if we look at the base of the pyramid, true prevention needs to start where we are reducing the intergenerational transmission of ACEs, and we're actually helping children overcome the effects and the symptoms of adverse childhood experiences. And Mark will talk more about that later when we talk about resiliency and positive childhood experiences. The ACE study was designed to understand how ACEs influence human development in predictable ways. And the reason why this is important is because if it's predictable, it's preventable. Next slide, please. The ACE study was unique in that it gave us the potential to understand multiple stressors that affect many important public health problems. Most prior studies to the ACE study on health and social effects of childhood abuse really just focused on one adversity, like, for example, sexual abuse. The ACE study, however, included multiple childhood stressors and measured a wide array of health and social problems. As such, it expanded the knowledge into a broader public health perspective. So the design of the ACE study started in 1991, and in 1994, the CDC provided the funding to conduct the ACE study through the Department of Preventive Medicine in San Diego. There were over 17,000 adults through Kaiser Health Insurance that completed the survey. The survey was about adverse childhood experiences, health behaviors, disease risks, mental health, substance abuse, and other health and social problems. Those taking the survey were ages 19 to 94, so wide spectrum of ages. Most were in good health, and they were all seeking preventative health care. And most had either attended or had graduated college. So if we think about this from a socioeconomic angle, study participants on average would be considered better off than the average American. So think a moment, and we're going to get into a couple slides here where we look at the percentages of the participants in the study and what they had for ACEs and what they had for health and social problems. So think about for a moment how ACEs might be common and how they might affect people in other socioeconomic groups. Next slide, please. So we have 10 categories of childhood experiences, and they were broken into three categories or three kind of subgroups. The first one being household dysfunction, and under that we have substance abuse, parental separation or divorce, mental illness. Violence in the home is specifically evidenced by a battered mother, and then criminal behavior, typically evidenced by parental or caregiver incarceration. Second category, neglect, broken into emotional and physical. The third category being abuse, emotional, physical, or sexual. So ACEs are common, but this leads to a sense of disbelief. Think about it again, the demographic we're talking about, 17,000 people on average considered to be better off than the average American. And here we still have evidence of abuse, neglect, and household dysfunction. This disbelief makes it hard for us to talk to people about ACEs and get them to embrace and understand that we have a real problem that we need to work on here. And we're going to need to create a paradigm shift. So if you feel like you've already been talking to people about this and you feel like you've been hitting a wall, you're really asking them to change the way that they think. We're asking for a change in human behavior, and we're really talking about a paradigm shift. So these findings really challenge us to kind of face our view of reality. And it's hard for us and for everyone to accept that children in our culture are commonly exposed to neglect, abuse, family violence, dysfunctional and chaotic family and living conditions. So keep this in mind when you're talking to people about this. They may not want to hear it at first. They may balk at it at first. They may not get it at first. And that's okay. We want to keep pushing forward because we really are talking about a paradigm shift here. Next slide, please. So the ACE score provides us a way to kind of summarize the cumulative impact of ACEs on health and well-being. It helps us provide a common language so we can talk about this. ACEs are highly interrelated, so it doesn't make sense for us to look at just a single category. And the different ACEs are not weighted. When you look at the ACE score, it's simply a count of the number of categories that someone either reported or experienced from 0 to 10. And those are the 10 categories that we just looked at. Each category is a single point. So for example, if a person experienced physical abuse, and this doesn't take into consideration how often or how severe, it could have just been one instance, it's still a ACE score of 1 point. If someone experienced physical abuse and a parent or caregiver with a substance use disorder, that would be an ACE score of 2. So the ACE score is truly a measure of that childhood biological stress dose that Steve was talking about before. And as the ACE score goes up, on average, the exposure to that developmental effects of that toxic stress also increase. Now take a look here. We can see that about a third of the ACE study participants had an ACE score of 0. But 16% of the ACE study participants had an ACE score of 4 or more. Now, a quick note about this. You're going to see this in the graphs that I'm going to talk about here in a couple of minutes. 4 or more is not a magical number. It's not a set point. Literally, when doctors Anda and Folletti were trying to report out the ACE study into different journals, they had to shrink the data because the data set was so large. And so they literally chose that point of 4 or more to be where they kind of wrap the data. It unfortunately gets misconstrued sometimes and miscommunicated that this is some magical number. It is not. It's not a set point. It literally was just a way for them to get the information into these journals and articles. Next slide, please. People who report a higher ACE score are more likely to have health and social problems. And that's basically what we're looking at here on this chart. As the ACE score goes up from 0 to 5 or more on the bottom axis here, people, or the percentage of people with those health and social problems, goes up on the left axis. This is what we call the dose-response relationship. You understand dose-response relationship. The more gas in your car, the further you can drive. The more caffeine I have, the more I can accomplish. Essentially, the higher the ACE score, the higher the likelihood of developing a health or social problem. Next slide, please. All the data that we're going to look at today is going to be formatted in the same way. So the bottom axis, or the horizontal axis, is going to be the ACE score from 0 to 4 or more. And that side or vertical axis is going to be the percentage of the population with the health problem or social problem that we're talking about. In the first set of data here, we're taking a look at people from the ACE study who reported being a regular smoker by the age of 12. And we can see that with an ACE score of 0, it's about 4%, and then it goes up exponentially in this, dose response fashion, stepwise fashion. By the time we get to 4 or more, and we're talking about more like 13% of people reporting being a regular smoker at the age of 12. If we look at the second set of bars here, we're looking at people who were reporting being a smoker as an adult. And again, we see that same stepwise increment as we go increase the ACE score, the percentage of people smoking goes up as well. The last set of bars here shows us how those with a higher ACE score are more likely to develop a chronic obstructive pulmonary disorder, or COPD. And so we can see that those with an ACE score of 0 had about a 4% occurrence of COPD. But for those with an ACE score of 4 or more, it more than doubles at 9% with COPD. Now, I'm going to break this into real numbers for you, because I know for me, I was like, 9%. Okay, what does that mean? Well, on average, right about now, there's 331 million people in the United States. So if we use this study as kind of a example for the population, which we can do, 16%, remember 16% of those that did the ACE study had a score of 4 or more. So 16% of 331 million is about 53 million people. So about 53 million people have an ACE score of 4 or more. If we then apply this category of COPD, 9% of 53 million is 4.7 million people who have COPD as a direct outcome of experiencing ACEs. Adaptive behaviors like smoking to deal with the effects of those adverse childhood experiences then led to the higher risk and then the development of COPD. So we have to think about those facts of adaptive behaviors and how that plays into this as well. Next slide, please. So I want to stop for a minute, because I don't know if you were a little shocked like I was the first time I saw that last slide and people who were regular smokers by the age of 12. But why is it that someone with a higher ACE score is more likely to be a regular smoker by the age of 12? What does it feel like to be a 12-year-old with a higher ACE score? Think for a moment about the effects that we know that ACEs have on the brain that Steve talks about. And it really leads to a higher likelihood of feeling depressed, anxious, and also having difficulty concentrating. Well, nicotine, which obviously we can get from smoking and vaping, can actually reduce the feelings of depression and anxiety, and it can actually increase concentration. So in a way, smoking is self-medicating. It's a coping and adaptive behavior for the negative outcomes that we're experiencing or symptoms that we're experiencing from adverse childhood experiences. So nicotine helps to replace and reduce those unpleasant feelings, emotions, or side effects of having those neurological changes. So despite knowing how bad smoking can be for us, despite whatever commercials we have or advertisements, people still smoke. They still use adaptive behaviors that they know aren't healthy. And this really relates to kind of that benefits analysis of, I know this isn't good for me, I know it's not healthy, but the benefits I'm getting from that reduction in anxiety, depression, and even increased concentration outweigh the fact that I know this isn't healthy or good for me. Next slide, please. So we can start to begin to anticipate why ACEs are related to certain behaviors and social conditions. Here we can see the risk of developing alcoholism increases sixfold from an ACE score of 0 to 4 or more, and that's the first set of bars on the left. But ACEs also affect relationships too, and people with a higher ACE score are more likely to marry someone who is an alcoholic or has a substance use problem, or is also at greater risk for violence in the home or being violent. And some of this is why we transmit it from one generation to the next. I experienced ACEs, and then I'm more likely to either have that problem of substance use myself or marry someone with that problem. And now my kids are going to be experiencing that as well. So when we want to think prevention, we have to really start thinking about that intergenerational transmission. Next slide, please. Depression is the leading cause of disability in developed countries, and the risk of the depression increases the stress dose response fashion as the ACE score goes up. So we see that here, that same stress dose response fashion. Relationships of ACEs to mental illness are extremely strong. We know that ACEs are held in the body. We know that that leads to mental, physical, behavioral health problems. And then some of these are unintentionally handed down to the next generation. So if I'm feeling depressed, I have a score of 4 or more, I'm a woman, I am 60% reported being depressed, the effects of that depression are going to impact my children as well. We have adaptive behaviors when we're depressed, like drinking, drug use, and those place a large burden on the individual, on the families, on society. And again, this is a major component of, we're seeing this, alcoholism, marrying somebody with a substance use problem, depression. These are major factors in that intergenerational transmission of ACEs. And so again, when we're looking to reduce ACEs, we're really trying to look at that, reducing that intergenerational transmission. Next slide, please. Here are a list of some of the health and social problems documented by the ACE study publications. And you can see that these are the things that we are talking about commonly, that we're talking about trying to work on and help people with within our society. There's a wide variety of health and social problems that are strongly related to ACEs. And this led the ACE study team to conclude that ACEs are the major public health problem in our nation. It isn't alcoholism and alcohol abuse. It isn't coronary heart disease. It isn't drug abuse. It is ACEs. It is the major public health problem in our nation. We need to think prevention, and we need to help others think prevention. But prevention means reducing ACEs and reducing the intergenerational transmission of ACEs. And if we're able to help people get that paradigm shift and start thinking that way, we are on a serious trajectory of really improving the health and well-being for generations to come. Next slide, please. Since the publication of articles from the ACE study, some states have also gone on to gather more information from their own state surveys of health. And this has allowed us to learn things that we just wouldn't have been able to get from the original ACE study alone. We know now that ACEs are a major determinant of homelessness, unemployment, incarceration, disability, learning problems, and poverty. So again, if we think prevention, we know that we want to address these things. We know that these are topics of conversation in, city government meetings, school board meetings, all over the place. But if we want to think prevention, we have to think about lowering ACEs and reducing the intergenerational transmission. Next. So let's dive a little bit deeper into ACEs being a major determinant of homelessness and poverty. We know that there are cognitive, attentional, and social outcomes that emerge from early trauma and stress. So take a look at this first circle here, those adaptations to toxic stress. Cognition, attention, behavior. We could have slowed language development. We could have trouble concentrating. We could have attention problems. We could have diminished IQ. We could have struggle with self-regulation. So all of these leading to risks like academic failure or early substance use or abuse, getting kicked out of school, dropping out of school, which is obviously then leading to adult adversity, which is putting us on a fast track for poor life outcomes. So these aren't character problems, right? These aren't character flaws. These are things that have happened. They've changed our brain. We've had these adaptive behaviors. These adaptive behaviors don't necessarily lead us to where we would ideally want to go. But just because somebody has a high ACE score, it does not mean that they are destined to follow this path. ACEs are not predictive on an individual level. They are only predictive on a public level, because positive childhood experiences, resiliency, protective factors can help change the trajectory, even if someone has had a high ACE score and has these adverse childhood experiences. Next slide, please. ACEs are common, they're interrelated, and they have a cumulative impact that is captured by the ACE score. Higher the ACE score, the greater the risk for health and social problems. Some of these health and social problems increase the odds of their kids having high ACE scores as well. The discoveries about the effects of toxic stress on the developing brain give us a biological plausibility for ACE study findings. And this is really important here. This means that we can conclude that the relationship between ACE scores and health problems is cause and effect. Again, when you were talking to people about this, we have the science behind it to say, nope, this is cause and effect. This is not just pie in the sky hopefulness. We know that adverse childhood experiences are putting people at greater risk for all of these health and social problems. Next slide, please. All right, this is actually my favorite slide, and I know that it's probably a little confusing to look at. So how do we take all of this great knowledge and information that we have about ACEs, and that ACEs are a powerful way and pathway to overall health and well-being? How do we use it to help create meaningful change? We have to get people to understand that the approaches we're taking now in our different silos, where we're just addressing the different kind of outcomes and symptoms of ACEs, isn't helping to reduce ACEs. So what you're looking at here in the center, this little oil slick, is the percentage of various health and social problems that epidemiologists estimate are caused by ACEs. And the calculation commonly used to do this in public health studies is called the population attributable risk. And you can see that some of these percentages are rather large. 65% of alcoholism can be attributed to ACEs, 51% of high risk for HIV, or 41% of chronic depression. So as we try to, let's say, address alcoholism, picture trying to push this oil slide. We're doing all these programs for alcoholism and we're pushing the oil slick, but all it's doing is shifting to other parts of the pie. We're not actually reducing the number of people who are facing health and social problems. So we can't just address this from the silos alone. Next slide, please. Here's another oil slick that's similar, talks about a couple of different topics like drunk driving, IV drugs, incarceration, serious persistent mental illness. Again, IV drugs, we know we have a huge problem. We have an epidemic. We're addressing it with programs and all kinds of things that we're working on, recovery-friendly workplace. We push that 78%, and all we're doing is just pushing the oil to another place in the slide. So we can't just work in the silos alone. What we have to do is we have to drill a hole right where it says ACEs, right in the center. And we have to start to reduce the intergenerational transmission of ACEs and reduce the negative outcome and impact of ACEs through positive childhood experiences and protective factors. Then when we work on our silos and say work on the substance use problem, we start pushing that oil around the 78%. But now instead of just shifting it to somewhere else on the slide, we're sending it down the hole and we're draining it. And we're actually reducing the percentage of the population who is struggling with these health and social problems by reducing the intergenerational transmission of ACEs and by reducing ACEs overall. So again, in thinking prevention, we're not thinking about preventing the top 3 layers of that pyramid. We're thinking about preventing and reducing the intergenerational transmission of ACEs and also helping those with ACE scores overcome through those positive experiences and protective factors. Next slide, please. I know I went through that pretty quick. We were behind. I was trying to catch us up, but here's really the most important part. We're now going to have time for you to go into your breakout rooms again. We're going to take 10 minutes in these breakout rooms. And what I want you to, I'm sorry, go ahead, Mark.
Steve and I made an executive decision. We should go for 5 minutes because we still have another whole section to get through.
Okay, you'll have 5 minutes in your section, so you're going to have to work quick, but you'll have time later on in the last breakout where you can come back and revisit this if you want to. So we're going to do 5 minutes, and what you're going to do is take a screenshot of this with a phone or just jot a couple quick notes. It's really, you're going to figure out how do you learn best. Just share that quickly with your group, like the one way that you know that you learn best, and just kind of talk quickly about how, okay, it's different, right? Some people learn this way, they're on that way, whatever. We have the list of the active learning principles down below. Don't worry, focus so much on those right now because we only have 5 minutes. But using what you know about how you learn best and learning what you know, using what you know about what you've learned about ACEs today and in previous presentations of it, we want you to come up with a learning activity that might help you teach some portion of what you've learned about ACEs today. And it's to the whatever demographic you work with the most common, whatever your target group might be. So let's go ahead and take 5 minutes to do that in our breakout rooms. Vicki, if you can go ahead and set that timer to make sure we're back in about 5 minutes. Thanks.
Excellent. Okay, thanks everybody and welcome back. Heading into the home stretch here. So Up until this point, we've learned about the neurological concepts and the impact on society with regards to adverse childhood experiences. The ACES study provides us with a straightforward informational framework about the consequences of toxic stress during childhood, and the scientific research gives us a lot of powerful information that we can use to improve the health, safety, prosperity, and longevity of our own lives, as well as that of our loved ones and within the community. But the ACES study in and of itself isn't a detailed roadmap for services and program. It's an invitation for us as purveyors of this information and those of us who are learning about it to learn how we can make a difference. And this information is really too important and too vital and too much of an insight into what can be done for waiting for somebody else to design a detailed roadmap. So through our collective knowledge and the actions that we are taking, such as today, we are the ones with the power to shift and the dynamics within our own families, within our own communities, and society writ large that lead to high ACES scores. So now we'll talk about some of the tools and the methods that are afforded to us to drive this shift in dynamics. Next chart, please. Thank you. So when people hear about the ACES study and the findings, they often ask about resilience. People get excited about the notion of resilience, primarily in part because it reminds us that our supportive actions and the work that we do in this space matters. Our desire for resilience leads to naturally to research ways to help our families and to help our communities. So what we're showing here are 3 protective systems that interact and guide positive adaptation within the community. Number 1, the first set of capabilities are individual capabilities. Number 2, attachment and belonging with caring and competent people. And number 3, protective community, faith, and cultural processes. So what do we know about individuals who do well despite their childhood adversities? Well, we know that the 3 protective systems are nested, that people do best when they are living in thriving families and communities, that we can help one another to develop personal attributes that help us all weather life's storms. And then finally, personal attributes like taking a positive view on one's life, our self-efficacy, and our self-regulation. All of these are discussed at length in the resilience literature, and we'll touch upon those in the next couple of charts. Next chart, please. So the first protective system involves building a positive view of oneself, myself, yourself, oneself. A positive view, it helps me understand that I'm important, I'm valuable, and it helps me to ask for help when I need it. So it comes with a dose of humility and being willing to ask for help and not rely on one's own self to have all the answers. A positive view is also closely related to hope, that together we can all formulate a coalition against these issues, and that they help me not to give up on myself and to give up on others. A positive view is also about the story that we tell ourselves that says good things can and do and should happen to me. And when we notice the core gifts that each person and each person that we meet provides, and help them the opportunity to discover those gifts and give them back to the community, we're less likely to be depressed. We're less likely to do things like quit school, pick up substances, participate in criminal behavior, and all of the other aspects and core impact that ACEs have on us as a society. Self-efficacy is the belief that when I have what happens to me and what I do influences rather what happens to me. Simple things that help build self-efficacy, like asking people to do things and to participate and contribute their time and their resources. They have real value for the community as well as the family. And encouraging a person to build these skills that are more complex and take time to develop is also a direct result of taking the time to build this community and rely on others and ourselves to overcome these difficulties. Self-regulation, it's our ability to gauge our own, it's a self-awareness to gauge our own state of mind, our emotions, and how to keep these under control while we are navigating a social situation. We remember this chart that Steve showed that showed the impact or the skills that are required for somebody who's a first responder, and how those may be different than somebody who perhaps is a social worker or somebody who is involved in social services. What we can't do and what we shouldn't do is read the situation and ignore the social aspects of what we do and how those have an impact. So there are a number of strategies for practicing self-regulation. Depending upon a cultural situation, these might include belly breathing, mindfulness, prayer, meditation, and other calming practices, yoga, and so on and so forth. Next chart, please. The second protective system that we can nurture is a sense of belonging. Here, many people talk about the importance of having other people in their lives, people who recognize and encourage our unique talents and our interests and our strengths. Relationships with caring and competent people are all vital contributors to building resilience and achieving recovery in our lives. Competency is noteworthy since it requires learning new skills and putting these skills into practice in order to help people who are hardwired for survival in a dangerous and unpredictable world. People who have difficulty with emotional regulation or picking up on social cues, problems with addiction and family bonds, or other consequences of developmental trauma can be challenging friends and neighbors. And not all of us enjoy being around these people when they're like that. And then relationships that provide security and belonging will become the norm as we learn and improve on these skills and our competencies that are relevant and helpful during times of stress and challenge, as well as during celebration and rest. Next chart, please. And the third and final protective system involves community. Here we hope that dramatically improving our health and our safety for this and future generations requires us to foster thriving communities. And fostering thriving communities, in turn, is about empowerment. It's about investing in the people who have the most at stake so that they can be expert leaders in their own communities and their own ability to make changes in their communities. So as an example, I like to think of like a peer recovery coach, for example, people who have walked the walk, people who speak the same language, and people who have the same lived experience that a person in need can identify with, all go a long way to building credibility as well as being able to provide services and help other people in safety. So as we invest in our community capacity, we can systematically provide this education about the neurobiology of ACEs, about ACEs as a whole, the resilience and things that we're talking about here, and building community resilience such that people can have a common language across sector and multidisciplinary work. Building community capacity is about helping people learn, manage, and improve their efforts systematically, and providing flexible funding, state-of-the-art education, and direct supports that can help everyone who wants to help mobilize everyone who wants to help. Public and private partnerships that foster thriving communities. These folks learn from these communities of hope and celebrate exceptional results from their work. So to learn more about capacity building, we'll look to communities that have changed the way people work together to solve these tough problems and have had stunning success. Success doesn't happen overnight. It's a journey that intentionally builds new capacities and supports healing and prevention in the community. Next chart, please. So we're going to do a quick exercise here. I'd like for you to either type in, we have directions, slido.com. If you could go to slido.com either through your browser or on your device and either take a picture of that barcode or type in the words SCPHN, Strafford County Public Health Network, and you'll be able to answer this question about listing examples of what you consider to be protective factors in the work that you do, or maybe even aspirationally. So we're going to take a few minutes just to do this.
Can you see that
Great
now?
examples here.
Yes, we can see it.
Okay, great.
Where the text is larger, that's where we have multiple iterations of the same factor. So this is good. Okay. Excellent. So maybe take a picture of that for your own, take a picture of that chart, and we're going to move on to the next subsection here on the community capacity development. All right. So while that's coming up, let me get into the conversation here. So many of us are working in the helping profession, like to use the phrase, or at least I do, I shouldn't say many of us, the end of the story has not yet been written. And I use that to refer to the recovery journey, where our past behaviors, our past experience do not necessarily doom us or place us in a determined destiny. Said differently, adverse childhood experiences are not written in stone. They are not a destination. They can be prevented. They can, in many cases, are prevented. So parenting adults have the most power, as we expect, to prevent ACEs, and we know that all over the nation, parents are stepping up to take the lead on this. So what can we do as an extended members of society in the community to help and support these parents? Next chart, please. So I'm going to talk about 4 different phases of building community capacity development here. And each successful community has the characteristics of each of these, but each of these communities is unique. Communities that have reduced social problems and difficulties in their community as a result of ACEs, they've reduced the percentage of young people with high ACEs score and have improved key factors for resilience. And the way they do that is through building over time these new capacities for helping one another thrive and aligning these resources and systems so that they achieve better results. So as an example, in Washington State, a community of public health and safety networks call these communities high capacity communities. And the processes that they've used is centered around building community capacity. So we have a 4-phased iterative process that we're highlighting here to nurture development of healthy and productive adults, regardless of the circumstances within which they were born. So it's kind of like breaking the cycle, if you will. It's an approach that invites all members of society and the community to shift the ways we engage with one another on a daily basis, improving people's connections, shared responsibilities, skills, and efficacy. This approach increases the collective impact of services and neighborhood initiatives by aligning these resources around the common purpose. The 4 phases are leadership expansion, coming together around issues of importance to the community, learning together, and 4, results-based decision-making. And we'll talk briefly about each of these in the next few charts. Next chart, please. So the first phase is leadership expansion. And what does this really mean? So high-capacity communities consider everyone who wants to help as a leader, and they in turn open opportunities for people to contribute their gifts and their talents to commonly held goals. In the case here, the commonly held goal is to break the cycle of adverse childhood experiences through resilience. So this workshop is a perfect example. Think about it. Here we have over 70 or 80 people who are immensely talented in their own fields coming together to build capacity to help others and to simply do our jobs more effectively. Diverse perspectives enrich solutions and enhance resources available for community improvement. And it doesn't need to be complex. So let's go to the next chart, please. And we're hitting the home stretch. The second phase of capacity development is coming together around issues that matter. Conversations that matter to community members that build social networks are an important factor for building this resilience. So as an example, in Washington, the Family Policy Council, they sponsored an education program and a series of events that provided assistance to communities to support this phase of capacity development. They held a Train the Trainer program to support group learning about emergent scientific discovery. And the strategy was effective in attracting an ever-enlarging circle of youth and adults who stepped up to commit to dramatically improving the future of public health. And as a side note here, you know, given where we are with COVID and where we are with some of the trauma facing our kids and our youth of today, I believe, and that we are at the precipice of having the same impact on within our own communities as we build resilience against the impact of COVID. Next chart, please. The third phase of capacity development process is shared learning. Again, an example being what we're doing today. It's especially valuable for communities to develop a common language and concepts, which is what this education is about. It helps reduce stigma, and it helps people get to a common place of understanding as to what the dynamics of adverse childhood experiences are and the impact on society. Something as simple as one person needing a book in order to complete a class and another person lending that book can be an important opportunity, an example of shared learning. Next chart, please. The fourth and final phase of capacity development involves putting our ideas into action, and it's about making decisions about next steps and developing action plans that go from the theoretical and the hypothetical into concrete actions and plans. And it's based on a future that we want for our children, our grandchildren, and future generations. These results-oriented or results-based decision-making processes can be challenging because naturally we are all proud of what it is that we've been doing in our own respective fields. However, in high-capacity communities, there is no blame, there's no failure, there's no right way or wrong way. It's just our collective ideas about building upon our previous successes. It's about learning, it's about adapting, and it's about implementing the best of breed exercises and processes that we can put in place to enhance decision-making in our communities. Next chart, please. So, supporting healthy community processes that respect cultural traditions and values is a high leverage activity. It's kind of like raising the tide so that we lift all boats. As a metaphor, it's a high capacity community, lifting all of the beings within our community across and oriented towards a common goal. Next chart, please. So it's really up to us in this room. It's up to us for those who are maybe hearing about this for the first time. You're not alone. And there's a predictable pattern of creating transformative change in our communities. It begins with discovery. It begins and continues with communication, which in turn leads the people to clarify their values and their thinking. Armed with this new knowledge and our new ways of thinking, people can change the way they act and the way they take actions in everyday life. Practice these principles enough times and it becomes muscle memory. These collective actions of many people shape a new reality that is ratified in organizational and policy change. The truth is that people create a new reality long before any laws or regulations are passed. So it's really up to us. It's shaped by our thoughts, our conversations, and within our communities, our relationships, and our families. So I'm going to close with this aspirational chart that Jody provided us. And you know what? It's really, there's no one way to get to the finish line. And if you want to characterize this as a finish line, it's a process, it's a journey. It's not necessarily a destination, but every journey begins with that very first step. So with that, we did intend to have one last exercise around ideating around next steps. Time permitting, I believe we still have the opportunity to do that. If we want to take a moment to do that, we're going to create another small group and come back and report out on what it is that we feel are the best initial steps that we can take as a team. I appreciate everybody that did stick around here, and you know, hopefully we quenched your thirst a bit, but at the end of the day, we hope you're thirsty for more information and the ability to work together here to make a difference. So let's see, I'm trying to recall, Jody and Steve, how we decided to do this, just to have one or two groups come back and just give a quick report out and examples of next steps.
Yeah, if we want to take a minute or two, if there's a group, I mean, you barely got to get started, but kind of out of your breakouts today, if you want to just share, we can take a couple people that want to just share either an idea that came up in your group for how you can take action steps right now. That would be great. Probably just unmute and share if you want, or put it in the chat.
Well, don't make me call on somebody because I see some familiar faces here.
I would invite Angel and Dolores from my group. Had some really good perspectives from our breakout sessions today. If you two would like to share, or either of you.
Hi, I'm Angel. So I'm a social worker at a primary practice in Strafford, New Hampshire. And I just kind of brought up in the past when I've mentioned ACES, some of the providers in my office haven't even known what ACES is. So I was just talking about even just at an office level, having more conversations with the providers and staff about what all of that means. And we had also talked about many of us are learners through kind of storytelling and what's the meaning behind it. So maybe specifically helping our providers to understand things through the lens of specific patients that they may be struggling with, or, you know, trying to better understand what's going on for that specific patient.
Excellent. Anybody else? I'm going to call on somebody.
Mark, can I just share something from our group?
Sure.
So the comment was made sort of at the previous activity, like, it's overwhelming. It's overwhelming. Where do we start? What do we do? I don't know where to apply this. And in our group, we talked about even just changing a word, you know, like the word maladaptive came up and it's being used where this person works. And it was like, it's not maladaptive, it's adaptive behavior. So even if we just start there and just start changing that word with the people that you work with, colleagues, and also the people that you're servicing, you know, that starts to chip away at the problem. So it can feel really overwhelming, but no question or answer is too small. So I just wanted to offer that reassurance, I guess.
If I can add on to that too, Jody, what you're saying, I don't know if there are people on this call, but yesterday I did a statewide training for safe messaging through NAMI, and it was fascinating. It was to really just how to talk about things like, you know, and to like take suicide, for example. That's such a sensitive topic, and how does the media address it, and are they doing it correctly? And so there's lots of different ways you have to think about safe messaging for things, and or even like categorizing something like, you know, like, oh, you don't say things like, oh, they're crazy. You say things like, you know, they have a mental health challenge or something like that. So like you're saying, just to change a word here and there to think about how you refer to things kind of does change how people view things in the conversation and the normalization of these things. So if anybody has a chance to do some safe messaging training, it's really worth it. And it was really fascinating. NAMI did a really good job yesterday, but that's kind of goes along with what you were saying, Jody.
Yeah, thank you.
Yeah, and I saw Carolyn's comment, and simultaneously with that, I was thinking about something that Suze and Jody and I talked about, and Jody actually created about a 30-second video that talks about instead of asking the question, what's wrong with you, what happened to you? And I would love to share that. I don't know who can share that, but I can get that out to all of you. I think you'll find it short, sweet, and profound.
I can, Ashley, if it's okay with you, I'll send it to you. And then as you send up the follow-up email, we can send that video out with that for sure.
Yeah, definitely.
Thank you.
And if anybody has questions that we don't get to, or if you'd like to share anything, please email, you know, the email that you see on your screen, the info@pimetreeinstitute.org. And you can also always reach out to us, and I'll drop our email in the chat at the Public Health Network, and we can help to, you know, get you connected with other people that you might have talked to, or with our presenters, or just with, like I mentioned before, our addiction task force to sort of join this work at a community level. We're always happy to have you. Awesome. Well, again, I just want to thank all of you for being here today, for staying, like Mark and Jody mentioned, the extra 20 minutes. We really appreciate it. I know that this information is definitely important. It's timely. You know, we might hear about it a lot. This might be your first time hearing it, but it is an important message to share. And we welcome your feedback, your input. We welcome, your collaboration. If there's I'm sure plenty of links and emails and notifications and things in the chat. We'll send out some follow-up information via email about this workshop, filling out this evaluation if you don't get the chance to do it now, and information about our upcoming workshops in this series. So thank you all so much for your time. I hope you have a wonderful rest of your day. And thank you to all of our wonderful presenters and our Addiction Task Force members for your help in making all of this possible.